Hi, I'm going to run you through anaesthetising the diabetic patient. There can be many different reasons why you want to anaesthetise a diabetic. One common reason is for management of the diabetes itself. For example, an unneutered bitch is unlikely to ever stabilise until you neuter her, so certainly spaying an entire bitch might be something you do relatively early in the course of disease. Also, you may be anaesthetising a patient for management of a diabetic complication. The most common reason for this would be cataract surgery. Obviously not something we do at your vets currently. However, the current thinking on cataracts is that the moment a cataract is noted, the patient should be referred for surgery as soon as possible, rather than waiting for the diabetes to be totally stable prior to it. So that would be quite a common reason seen at referral centres. However, in general practice, probably the most common reason is something that is nothing at all to do with the diabetes, something such as a dental, a lump removal, or other general surgery. If at all possible, anaesthesia should only be performed on stable patients if you have that option. However, if the patient is not stable, then you should make a decent effort to ensure it is not ketotic. Ketotic animals are very, very high risk for anaesthetics, and really they should only ever have anaesthesia performed on them if it's an emergency situation where they cannot wait until they're stabilised. The other thing to remember if you have an animal who isn't stable is you have far less risk from running a diabetic too high than too low. In humans, we worry about getting very, very fine control of diabetes because humans can suffer from quite severe complications of having too high blood glucose. Animals, for short-term periods, running a little bit high is very unlikely to cause them any harm, so it doesn't tend to be something that we greatly worry about. Now, the traditional thinking that most textbooks will go through is various protocols, all slightly different, but they're all based around the following principles: that we withhold the food from the animal overnight, we do the general anaesthetic first thing in the morning, and you give approximately half a dose of insulin first thing in the morning. Some protocols advocate measuring the blood glucose and giving a dose based on the result. For example, if they're less than a certain amount, say 7, you might give them just a quarter dose as opposed to a half dose. You can find various protocols in different textbooks. You then measure and monitor the glucose throughout the procedure until they're eating post-surgery. For most animals who'd be on twice daily insulin, you would then just give a normal dose of insulin in the afternoon. For animals who are on once daily insulin, then you may actually give a half dose at the point they start eating, which is probably late morning, lunchtime time, to tide them through to the next day, because their next dose of insulin wouldn't be till the next morning. However, when you actually look at the evidence base behind these, there isn't much evidence showing that these protocols are particularly good, bad, or ugly. The studies which have been done have shown that these regimes result in really, really unpredictable blood glucose levels. So there's no evidence that these are particularly safer than any other aspect, and there's equally no evidence that giving a half dose won't throw animals too low, for example. So the real question is, why do we try and alter diabetic animal regimes? Why do we change what they're doing? And the normal answer is that we want to give them a 12-hour starve, which obviously influences how much insulin we can give. However, there was a recent study done at the Royal Veterinary College in about 2012, and it showed that the risk of GI reflux under general anaesthesia, which is our main reason that we starve anaesthetic patients, is only running at about 1%. And the main risk factors for the majority of animals who have this reflux under anaesthesia are animals who are having either orthopaedic or neurological surgery, normally quite prolonged, quite invasive surgeries, GI surgery, which is not surprising that if we're sort of squeezing on the stomach and the intestines, there's a higher chance that we might see some form of reflux. Animals who are very large, greater than 40 kilograms, or actually animals who have a very long starve, a starve over 6 to 10 hours. So an overnight starve actually seems to give us a slightly higher risk of having reflux under anaesthesia. We also have got studies that show that wet food given 3 hours before anaesthesia does not increase the risk of regurgitation. Now, most anaesthetists tend to be a bit more cautious than saying a 3-hour starve, and most anaesthetists seem to feel that the recommended starve period should be more to do with 4 to 6 hours time. This poses an interesting question, because if we gave an animal its normal morning insulin, which most owners are giving between 7 and 8 a.m, you could be doing the operation just after lunchtime, which for most of our surgeries still fits with when we're doing operating time. So the protocol that is being suggested, and I believe is currently in use at the Willows Referral Centre in the Midlands, is that they aim for a 5 to 6 hour interval from the last meal and the morning insulin through until the time the surgery takes place. Obviously, you can make slight alterations to the timing of the meal. So if the animal normally would only eat at 10 a.m, you might say, well, bring it forward an hour, hour and a half to try and fit in a little bit better with what suits the practice. Equally, you can alter the timing of the op if that suits your clinic. So an animal that always has a 6 a.m, you might do a little bit more late morning than early afternoon. The owners would feed and give the insulin as normal. They would probably want to bring the animal in a bit later, because what's the point in the animal sitting in the kennels for that 5 to 6 hour starve? It may as well be at home for that time period, so we keep its regime as normal as possible. And we don't do anything different. We take blood glucose at the time of induction, and then every 30 to 60 minutes during the op we take a blood glucose. Most of the time, because these animals are coping well with the dose as well, the blood glucose will remain relatively normal throughout the surgery. And if so, then you feed or give insulin as per the normal schedule. There's no need for any different regime afterwards. If it goes low, then obviously if it's during the operation, you'd spike some glucose into the fluids. If it's after the operation, offer additional food and potentially also spike glucose in the fluids. And I'll give you a recipe for spiking glucose in the fluids later. However, just to be clear, the majority of animals, provided they're stable before the surgery, there is no reason that they should go low through this surgery. Other things to consider regarding general anaesthetics. Diabetic animals are more prone to having hypotension, both because of the PUPD that they show and also there's alterations in their autonomic functions, their ability to vasoconstrict and things like that. Therefore, all diabetic animals should have fluids as part of their protocol. Hartmann's would be an ideal choice as a balanced fluid solution, and I've given you a little recipe here of what to do if the blood glucose does fall to less than 5 millimoles per litre, and basically it involves spiking it with a little bit of glucose solution. Just be aware, 5% dextrose is not a suitable fluid to use for these animals. The dextrose is just metabolized immediately and leaves free water and is not a balanced electrolyte solution, so that would not be a good choice. You're far better to spike Hartmann's, or actually you'd be just as good to spike sodium chloride. When we admit a diabetic for anaesthesia, it is a good idea to have a checklist so that we know exactly what's been done. Even though we might have given them relatively detailed instructions, it is a good idea to be able to make sure that they have understood and followed them. So we want to check for any recent history of hypoglycemic events or being off colour, anything out of the ordinary. If we are having any of those, then a vet should be involved, because it might be that this animal has become unstable, and as we said, if it's an elective surgery, we should be delaying it until the animal is stable. Did they have insulin and food today, and if so, how much? Just checking that if we told them to give the food at, say, 7 a.m. with some insulin, that they did actually do it, that the message didn't get lost in translation. What is the normal regime? If they're anticipated of being in for a longer period of time, so say for example we're doing a quite painful surgery and we expect that they might need to be supported with analgesia for a 24-hour period or even longer, then make sure they bring in their own insulin and you know what type of food they give, how much, when, these type of things. And also asking if they're on any other medication. If they are, we should always check with the vet to make sure what we should be doing regarding them. Have they been given? Should they be given? These types of questions. Pre-med. The pre-anaesthetic medication should be tailored to the patient's needs. However, Ideally, if we get a choice, drugs with a minimal hangover effect, as these will lead to a faster recovery. So good choices would be things like quite a low dose of ACP. Some opiate would be not a bad choice. Just remembering that if you're looking at opiates, try and avoid morphine because it can cause vomiting and nausea, which isn't ideal in the diabetic patient, where we either might lose the calorific intake for the day or make them not want to eat it if they're feeling nauseous. Ketamine and midazolam is quite a good sedation, a pre-medication protocol for cats because it gives a good degree of sedation with quite minimal side effects. But just remember things like Domitor and midatomidine should really be reserved for cases who really need it. So if the animal isn't manageable without it, then obviously use it. But remember that this is an insulin antagonist, so blood glucose will rise after administration, which can make monitoring these animals quite difficult. When we're monitoring a diabetic patient, just be very aware of the oxygen saturation. Diabetic animals actually have decreased oxygen transport. The haemoglobin doesn't carry as much oxygen as a non-diabetic animal. So therefore, what you want to be aware of is two things. First thing, making sure you select the correct circuit and making sure you get a high enough fresh gas flow rate for that appropriate circuit so that you're ensuring these animals have ample oxygen delivered at all times. Second thing is maintaining their oxygen a little bit longer. Whilst in most patients the last bit of recovery is often done in the kennel until the tube is taken out, in these patients you might want to keep them on oxygen until they're ready to be extubated. Blood pressure. We already mentioned that these animals are prone to hypertension, so we should aim to maintain their blood pressure between 60 and 100 millimetres of mercury if you're looking at a mean blood pressure. If you're looking at systolic, you want to maintain it a little higher, which is 100 to 150. Obviously, not all of you have blood pressure monitoring for during anaesthesia, but don't forget that your standard Doppler will take a very good blood pressure measurement during an anaesthesia, and these are the type of patients where maybe you want to take a couple of these measurements during a standard procedure so that you can have a look and make sure that you've got everything going correctly. If the blood pressure does fall low at any point, then the things that you want to think about is first off making sure that you've got the depth of anaesthetic correct. A lot of the time a low blood pressure will be caused by the anaesthesia becoming a little bit too deep, so turning it down if that's possible with the animal. Increasing the analgesia is the other thing because that often enables you to lower the ISO concentration. Beyond that, giving a bolus of fluids, and a crystalloid is absolutely fine, is my normal next step. And that should be a bolus. So rather than having, say, turning a fluid rate slightly up, you should be thinking about giving a bolus over a 5 to 10 minute period. So they're simple things to try and increase blood pressure. Analgesia for diabetic patients. As with most analgesic plans, we want to think about a multimodal plan. Multimodal plans minimise each drug's dose, so we minimise any potential side effects. We've already said with opiates we should try and avoid morphine due to the nausea and vomiting. But the other thing to remember in opiates is they can be prone to have a mild sedative effect, which obviously in diabetics we want to get them up and acting normally as quickly as after the anaesthetic as possible. So we want to minimise this. So rather than giving a fixed dose of an opiate, you may be better to titrate to effect. So if, for example, for an individual patient you'd normally give, 0.3 mg per kg of methadone, potentially try and give 0.1 mg per kg, see how they are. If they're still painful, give another 0.1 mg per kg. Are they still painful? If so, go up. And with a lot of these patients, you'll find that you can control their pain at a little bit less than what would be the high fixed dose, and therefore get them feeling better and eating and stuff much quicker. Non-steroidals, absolutely fine to use in diabetics, but if we are using non-steroidals in diabetics, we need to be aware of that risk of hypertension and make sure that we don't allow them to become hypotensive, because if they do, that could potentially risk of renal effects. And the other one to remember is locals. A lot of diabetics come in for things like dental procedures, and obviously having a sore mouth afterwards can make us unlikely to eat, particularly in the immediate post-op period. If you did some local blocks when removing the teeth, you will have a much more comfortable animal, and you'll probably prevent some of the sensory wind-up, so meaning the pain post-operatively is also less. If you don't feel confident doing the nerve blocks, don't forget splash blocks, where we just splash a little bit of lignocaine onto the extraction site, are a very valid way of providing additional analgesia. The final one I wanted to mention is if you have a ketoacidotic animal. Ketoacidosis is a life-threatening emergency. So if we do have a ketoacidotic animal presenting for anaesthesia, it is the type of thing where I would say you really do need to stabilise as much as possible. Just as when we have a gastric torsion coming in for an op, we know the torsion is going to kill them if we don't deal with it. However, we don't knock it out straight away. We do spend quite a period of time stabilising them, otherwise they wouldn't survive the anaesthetic to solve the problem. And ketoacidotic animals, if they require an anaesthetic, it should be exactly the same principle. We don't do the anaesthetic until they've got them as stable as possible. Obviously, we should only ever be anaesthetising ketoacidotic animals if it's an emergency. They are high-risk patients, and we really shouldn't be doing this unless we have to. They normally are incredibly dehydrated. Their electrolyte balance is all over the place, which can lead to things like cardiac arrhythmias. And they also have metabolic acidosis, which can be a huge risk. Often these patients will need ventilating under anaesthesia. Finally, the renal function would be another thing that we would have real trouble with. So if a ketoacidotic patient comes in that requires an anaesthetic, it really should be something that has a high level of veterinary input. Most vets will need to go to textbooks and look up as much as possible. However, the other thing to remember is there is absolutely nothing wrong with stabilising them as far as possible, because these are such a level that potentially they should be a referral level anaesthetic. Right, thank you for listening.